Hello and welcome. I'm Vismita Gupta Smith, and we are coming to you live from the 77th World Health Assembly here in Geneva, Switzerland. Behind me, you can probably also hear them in the background. Delegates from 194 countries are here to talk about health as it impacts you. So there are some big decisions that are being discussed, like the pandemic agreement to protect the world whenever the next outbreak or pandemic happens. If that happens, how can we prevent it? How can we prepare for it? Decision was taken that the delegates and countries will continue to work on the pandemic agreement. There's also on the agenda was the international health regulations and strengthening it. Again, work will continue on that. There are a number of resolutions that have a direct impact on your health. So today, in our live, we are going to talk about you and how when you need health services, what role do those health services play in your life? For instance, our audience could be watching us from your living room in a big city or a remote area, or you could be a younger person or an elderly person. When you need health care, is that affordable for you? Is it accessible for you? Do you get quality health services when you go to your healthcare provider, for instance? We are going to unpack all of that today, and then we will take questions from you as well. So remember to put your questions in our timelines. Use the hashtag AskWHO. Also, remember to tell us where you're watching us from. I'm going to introduce you first to our panel. On my extreme left, Dr. Raquel Child, Director, Office of International Relations and Cooperation, Ministry of Health in Chile. Welcome. On my left, Dr. Suraya Dalil. Dr. Dalil is the Director for Special Program on Primary Health Care. On my right is Dr. Viroj, and I'm going to try and get your name right, Dr. Viroj. Dr. Viroj is a legend in public health, but let me get his name right. Is it Tangchelan Setian?
Yes.
Did I get that right? Thank you. Dr. Viroj is the advisor on global health to the Ministry of Public Health in Thailand. So let me first start with you, Dr. Suraya. Paint us a picture of if I was a woman living in a rural area and I needed health services, what should that health service look like? And explain to us this concept of primary healthcare approach.
Thank you. My greetings also to colleagues and people and friends who have logged in. Primary healthcare means providing healthcare closer to where people and communities live, closer to their daily environment. It means that looking at health from a holistic perspective, looking at a person's health and well-being from a holistic and totality perspective. It means that taking care of people when they are sick, but also when they are healthy, which means in terms of disease prevention, in terms of health promotion, in terms of looking the broader aspect of health. And that's what primary healthcare means. Now, if you're a woman in a place in a rural area, a primary healthcare approach to you means that you have a facility to go to. And you know that facility, you have been there before, it's not the first time that you go there. You know the team that's working in that facility, and they
know you.
And they know you, exactly. And it's a multidisciplinary team, which means, depending on the context, it could be a physician, it could be a family physician, or not necessarily. It could be a nurse, it could be a midwife, a vaccinator, and also pharmacist, or all of them together, but also a community health worker that knows you as an individual, knows your circumstances, knows your condition, health condition, and beyond, and you trust that person. And that's very important, the trust aspect, that the relationship, the binding relationship, and the trust you have with the healthcare provider. So that's what primary healthcare approach means. I would also like to bring that primary healthcare approach means working with others for health.
What does that mean?
Exactly. Especially, I'm speaking that in the context of the World Health Assembly, where we have ministers of health and government officials present this week in Geneva. It means working with others, working with education sector, working with finance, working with agriculture and food, working with trade, working with transport, with rural development, with urban development for the whole issue of health. So a holistic perspective at the level of individuals, families, and communities, but also at the level of policy making, at the level of decision making.
So, Dr. Soraya, this is your daily work to work with our partners, with countries, to move closer and closer to this ideal picture. But let's come to some examples. Dr. Viroj, I want to come to you. Talk to us about, for a Thai national, when they need services, and you have a very good geographical reach for your services. Talk to us when they walk into a primary health center. What are the services they can expect?
Thank you. What Suraya said has been translated into action since 1970, well before the Manhattan Declaration in 78. This means the successive government invest in primary health care with an aim of 100% geographical coverage of one district hospital in a district, in all districts. And we have achieved in 2000 600 district hospitals in all 600 districts. Secondly, to achieve 100% coverage of sub-district health centers. A sub-district cover 5,000 population, a typical catchment area of 5,000. Then we achieve 8 or 9,000 health centers in all sub-districts, so that this brings health to the people. It was functioning because we have health workers who are very well trained. Today, all are bachelor degree, MD 6 years, pharmacists now 6 years trained, nurses 4 years, nurse and midwife 4 year trained, dentists 6 year trained. They are posted in district hospital, and nurses are posted in sub-district health centers. This quality service brings trust. How we maintain this health workforce in rural areas? We train them, we recruit them from the rural communities and train them, please go back to your hometown. So recruitment from local communities for 6 year, 4 year, 5 year training on a condition that please go back to your hometown with a incentive. Apart from salary, we have hardship allowance, we have whatever to keep them. Then retention in rural area. Thailand has implemented all the recommendations, 16 recommendations by WHO on retention of health workforce in rural area.
So these are really important things that you're flagging: retention of workforce, training, making sure that health workforce goes back to the places they have come from. Let's come back to that in a minute, but let me come to you, Dr. Childs. If you could talk to us about, paint us a picture of what it looks like in Chile when somebody goes to a healthcare center.
Thank you for this opportunity, and hello to everybody around the world today. In Chile, we have a very strong primary healthcare system all over the country. Chile, as you may know, it's a long and thin country, and we have people concentrated in 6 or 7 main cities, but all the rest of the populations live spread all over the country, all along the country, I would say. So when people need health support, they can go to the primary health care center close to the place where they live or they work. We have a very strong structure in this regard, so the coverage is almost 98% of the population has access to these services. So, even being national or coming from abroad, legal or not legal inhabitants of the country.
So these are some pretty vivid pictures of what done in relatively resource-constrained settings as well. Let's go back and talk about how trust is built during peacetime so that when there is an emergency, people will trust their health agencies and follow their guidance, right? Thailand has a very good example coming out of the pandemic. Please talk to us about that.
During pandemic, Thailand, I think, ranked 5 of the GHSI, Global Health Security Index. Worldwide, we rank 5. And our mortality per million is very low, much lower than US, which is ranked 1. So that means the difference is the trust of population in government advice recommendation on public health and social measures. The face mask coverage is very high, 100%. Then that means trust was built by the confidence in the quality of medicine, the competency of health workforce, the quality of dentists, pharmacists to prescribe, dispense you high quality medicine. That trust has been built during the last 4, 5, 6 decades. And trust has been proven during the pandemic that adherence to public health and social measures is very high. And the pandemic containment is very good in terms of excess death is much, much lower than other countries whereby they have a lack of trust and misinformation and disinformation during the pandemic. After the pandemic, we recover, of course, some of the essential services was affected, was disrupted during the lockdown and pandemic, and quickly recover because the health system has high resilience to recover, bounce back quickly because of the high quality health professional, and they have a high ethical conduct in providing services with high dignity.
So during the pandemic also you were able to make sure that health workers are, for instance, paid regularly, which in many places that wasn't happening. In fact, Thailand increased their remuneration, right? Speak to us about that.
During the pandemic, we mobilized 1 million village health volunteers. One volunteer covered 10 households, and they mobilized social capital to support a household affected from COVID. Government has decided to increase their remuneration honorarium to 2,000 baht, which is about $60 per month. During the pandemic, they are fully recognized by the citizen that they quarantine the infected person and provide food and shelter, etc. So we mobilize social capital through village health volunteer.
So I want to come back to you, Dr. Suraya. Talk to us about how even in resource-constrained settings, you can build a resilient system based on the primary health care approach.
Absolutely. I will give the example of building a house. When you build a house, your house or our private house, we start with the foundation. We don't start with the second floor of the building or the third floor of the building. we start with the foundation. What does that mean? It means that you make sure, in order for you to have a strong house that could survive flood and earthquake and so on, your foundation is strong and solid, and that's how you start. And then you decide, okay, but you build the first level and then all of that. And this is so important because for the services and for the system, you need to have a very good foundation that your building and your house will rely on. The stronger your foundation is, the better you can respond to the outbreaks, the better you can prepare for the outbreaks. And COVID-19 was a pandemic of extreme kind that our generation have seen, but we have also witnessing flood, earthquake, and really some of them are really severe. And that's why the primary healthcare approach has taken a lot of attraction. It's because it makes your health system to stand firm, to deliver effectively, and to be resilient. So I would also like to bring the fact that in primary healthcare approach, people, individuals, families, and communities have been given due consideration. What does that mean? It means that through applying a primary healthcare approach, we're not looking at people only as patients, but also in their own right, as our right holders. So they have role in taking care of themselves, which is self-care. They have role in giving care to their family members if they want to. They have a role in advocating for better health and more health. They have a role for demanding for more funding allocation for health, including for primary care. And they have a right to ask for more accountabilities for health. So that's why people, individuals, communities are empowered to do that, and they have the right to do that. So, and that's why the equity comes into this.
I want to talk about equity and how you have built that into the Chilean and the Thai system as well. But first, let me take some questions from our audiences. Let me know which one of you would like to respond to this. Aman Anand wants to know what is the role of women in primary healthcare services. Any thoughts? Let me come to you, Dr. Raquel from Chile.
Thank you. Well, almost 90% of the healthcare workers are women at primary health care services. So I think we, as women, have a critical and key role in providing what people need as health needs, health promotion. So I think, I would like having more men providing similar services, but our traditional role is providing care, promoting health in our families and communities. So yes, that's what it happens in Chile. But I insist, I would like more men to be involved in this.
In the formal sector, do you have more men or women?
Half and half. Yes.
Very good, I would say. Already better than many other settings. Dr. Viroj, women and their role in primary healthcare services.
Just to confirm what our colleague from Chile said, 99% of nurses are female. Now, female doctor outnumber male doctor. We have 70% because they are more hardworking than boys. And I would say pharmacists also 60-70% female. Then estimate more than 80% of volunteers are female. Therefore, they have more sensitive to health of the population, more providing more human service. Most importantly, We have 4-5 Muslim majority provinces. We have female doctors who are Muslim. We have female nurses who are Muslim, and they can entering to the household easily and provide services at home. Then this is cultural oriented, cultural sensitive, because we recruit Muslim boys and girls to train nurse, doctor, pharmacist, and hometown placement go to your hometown. So this has been proven consistently that hometown placement, local recruitment, training of health personnel is a sustainable rural retention of health workforce.
Another question, maybe you could perhaps help Dr. Suraya. Can you, this is from, I can't tell the name, Jefferson 91 is the name on Twitter or X. The question is, can you define healthcare and health services or differentiate between them? Is there a difference?
That's a very good question. So services are the provision of, for example, immunization. That's the service. For example, consultation, medical consultation, checking blood pressure, like blood tests, and so on. These are services. But care is more than that. Care care includes aspects related to determinants of health, the social, the economical, the environmental determinants of health, the disparities, the inequalities that drive ill health. So these are all coming under the care. So the care is more than, like, it's not only when people are sick and you provided services, but care means that you take care of them not to become sick, which means disease prevention, which means health promotion, which means the whole range of services and beyond.
So I have another question from Usman in Afghanistan. And he wanted to know, I think this is a key question that Usman is asking about retention of female health staff in rural areas, especially when there are no facilities like education for kids and health care for their families and stuff. Any thoughts on that?
I would like to come in that Dr. Wiru just spoke about retention of health workers, and I think that is key because it's not only about the training of the health workforce, it's also about retention of the health workers, especially in rural areas, and especially in a country like Afghanistan, because the question was specifically from Afghanistan. Now, the female health workers' retention in a situation in a rural area like Afghanistan, it has multiple factors. One factor is about financial incentives. It's about remuneration. It's about adequate payment for them to encourage them to go and to stay in those areas. But it's more than that. It's far beyond that. It's about living condition. It's about their children being able to go to school. We had a side event on Monday here at the margin of the World Health Assembly, and one of the ministers spoke that when staff, even in countries that are stable and they are in terms of security they are much stable, it's like staff ask about school for their children. What about school for their children? What about other facilities, like living condition for them to stay in rural areas? And that's why the whole aspect of rural development, the whole aspect of sustainable development comes into play, because then you see that community as a whole, and you say, okay, health is one aspect of it, but there also need to be schools, there also need to be like water and sanitation and electricity and other standards of living in order for them to go. Now, going back to Afghanistan example, also something that we did in Afghanistan many years ago was encouraging recruitment of female with their male family members, like couples, recruitment of them to go to certain areas, or sister and brother, to ensure that they are at least their support. But also the whole policy around it, policy in terms of making sure that there's a good accommodation, that especially if the Ministry of Health and the local governance can look at that one, appropriate accommodation, some professional incentives, career development opportunities if they work in the rural areas. So these are some options that could incentivize this one.
Right. So we've seen yesterday, I think we were talking to a member state where even in well-resourced settings, this is a problem that health workers may or may not find it, may not have the incentive to work in rural or harder to reach areas, right? Dr. Viroj, how have you achieved such geographical reach, and especially when it comes to retention of women?
As Suraya talked about Afghanistan, we provide financial incentive, non-financial incentive, including career path, post-grad training, all the housing. In every district hospital, we have dorm for nurse on call 24 hours, on call on night shift, so that they are safe in traveling. So they stay at dorm, and dorm is fully subsidized by the government, by the MOH. At sub-district health center, we also have house for staff. We have 3 to 8 staff, but mostly they are local people. Then they can travel home. Health center, we don't have night shift. We have evening service until 8 or 9 p.m. So all this, most importantly, social recognition in terms of the best rural doctor of the year, the best nurse and midwife of the year, best pharmacist by medical council, by medical association, by nurse and midwifery council. This social recognition is a pride of being a health workforce. So this social recognition is also, it is a routine annual recognition.
Recognition. And so talk to us about Chile and how you achieved even close to 50% female health workers.
Most people working at primary healthcare level, they live around the health centers. They are local people, so they go out to study, to make some professional building capacities, but they go back to their places. But that's not what happens with physicians. Medical doctors usually don't belong to the place where they are working. In Chile, there is a system in order to access to specialties. You may go to a place, I don't know, maybe 1,000 kilometers from the place where you belong to. You spend 5 years there doing primary health care, and then you have the possibility to go back to capital city or to the university you want, where you want to have to increase your capacity and get a specialty. So medical doctors usually don't belong to the places where they are working at. But for the rest of the health team, they are local. They go out for a short short period for building capacities, and they belong to the place. So that allows something that you were talking about, Suraya, is being very close to communities, knowing what happens with them, supporting them in different areas. So I think it's a very good solution for people and communities.
We're going to wrap up very soon. I'm going to ask our audiences to let us know where you're watching us from. But before we end, I want to come back to Thailand and Chile. Talk to us about the most important initiatives or approach that you took which makes your health systems resilient. The top line. So would you like to start? Something that makes the Chilean health system resilient. What is that one factor that you'd like to speak about?
Yeah, extremely good question, because we have just celebrated 100 years of the existence of the Chilean health system, the public health system. So what we have done is working closely with communities, with universities and health universities, having contact with international organizations, and working with people. I would say that's the main thing that has allowed us to get good results in.
Factors contribute to health system resilience. One is adequate funding. Second is the competent health workforce. Finally is the social participation, involvement, engagement by the community through VHV, through many activities that primary healthcare work with the community. So these are both demand side and supply side characteristics. When the primary care belong to the community, they will protect and they will safeguard and improve the quality. Therefore, these are the three factors. Yeah.
When the primary health care belongs to the community, they will protect it. Dr. Suraya, I'm going to give you the last word on what WHO's recommendation is for resources for primary health care approach. But before that, I'm going to read out all the names of countries where our audience is watching us from. So we have Afghanistan, Nigeria, India, Sri Lanka, France, UK, USA, Sweden, Australia, Nepal, Canada, Spain, Italy, Mozambique, South Africa, Indonesia, Bangladesh, Botswana. Back to you on resourcing the primary health care approach.
Resources allocation to primary care and to the health systems that are oriented towards primary health care is a key ask, is a key recommendation that WHO puts forward. What I would like to quote what Director General Dr. Tedros says, that health is not a cost, health is an investment. So it is an investment. And ministries of finance and governments should not see it as a cost, rather as an investment to the health and well-being of the population, because it will pay off. If we don't invest in health systems that are oriented, that are founded on primary health care approach, then we have to spend more on when the crisis comes. You know, whether these are in terms of spending more in terms of lives or in terms of money, spending more. So allocation of government resources, domestic resources in health and to primary care. And design, orient health systems that's based on primary health care approach. What does that mean? It means health systems that in its design, in its essence, in its philosophy has equity, human rights, social justice, compassion, in its core, and community in its core. So, and that's how you become health system responsive to the people's needs, makes it resilient, and makes it oriented towards primary health care. It's an effort that has to be done consistently and consciously.
Right.
It doesn't happen.
And say now it's done and we're going to stop, right? It's an everyday work.
So it's everyday work. It has to be designed that way that you put people at the center of the decisions. You always take into account people, their needs, their preferences, their situations, their conditions. You take people into account and you design the health system, you redesign, you reorient, you design again in order to take into account people's needs, people's expectations, and people's preferences.
Thank you, Dr. Soraya. Thank you, Dr. Raquel. And thank you, Dr. Viroj. So that was our live today. Stay tuned for the coming days to hear the latest from the World Health Assembly. Until next time then, bye-bye.